So welcome to everyone to the O'Brien Institute for Public Health and Community Health Sciences weekly seminar series. My name is Katie Chaput, and I'm a perinatal epidemiologist and assistant professor in the departments of obstetrics and gynecology and community health sciences here at U of C. And I'm also the epidemiology representative for the graduate education committee in community health sciences. And today is our sections day to fill this seminar space. So I'm really excited that we have Dr. Julia Maraca presenting. And I'd just like to, I'll start by acknowledging, I'd like to take this opportunity to acknowledge the traditional territories of the people of the Treaty 7 region in southern Alberta, which includes the Blackfoot Confederacy comprising the Siksika, Piikani, and Kainai First Nations, as well as the Tsuut'ina First Nation and the Stoney Nakoda, including the Chiniki, Bearspaw, and Wesley First Nations. The city of Calgary is also home to Métis Nation of Alberta, Region 3. So I'm going to go ahead and introduce Julia in a moment. There will be a Q&A session. You can use the Q&A to ask your questions, and we'll go through those at the end of Julia's presentation. When we finish up, if all of the questions haven't been answered, the presenter will receive those outstanding questions and may contact you with responses afterwards to follow up. So it's my pleasure today to introduce Dr. Julia Maraca. She is a perinatal epidemiologist and an early career investigator who's an assistant professor in the departments of obstetrics and gynecology and health research methods, evidence and impact at McMaster University. Her research is in the area of maternal, fetal, and neonatal health and health services research with emphasis on care quality, accessibility, and equity. Dr. Maraca received her PhD in epidemiology from the University of British Columbia, where her doctoral research characterized maternal and perinatal morbidity and mortality in deliveries requiring forceps, vacuum, and cesarean. She completed a postdoctoral fellowship in clinical epidemiology unit at the Karolinska Institute in Stockholm, Sweden, where she developed epidemiologic approaches to identify optimal intrapartum intervention rates, such as the cesarean delivery rate or the rate of induction, that minimize the frequency of adverse maternal and neonatal outcomes, including postpartum hemorrhage, obstetric anal sphincter injury, maternal sepsis, neonatal sepsis, and birth injury. So I'm really excited to have Julia presenting for us today. We try to, when we have the Epi section seminar date, we try to present things that show really innovative methods and applications of epidemiologic research to tackle complex problems in health. And I think this is going to be a really great example of that. So with that, I'm going to sign off and I'll pass it over to you, Julia. Welcome.
Thank you. I will begin to share my screen, and I hope that it goes without a problem as usual. Let's see here. Everyone see my slides?
Looks great.
Looks great. Yeah.
Wonderful. Okay. Thank you so much, Katie, for that wonderful introduction and for that land acknowledgement. That was really beautiful. I'm really excited to talk to you about, I have a million things to talk to you about the safety of forceps and vacuum delivery, really. So I'm going to launch right into it. I'm going to try to approach the kind of the questions around safety from different perspectives. I've put here interhospital to international because that seems like opposite sides of a gradient, but really from a multitude of different perspectives. So I'm just going to launch right in. I have no conflicts of interest to declare. And I wanted to just give you a bit of an outline about where I'm going to take you this journey over the next, half an hour to 45 minutes to give you kind of a sense of what we're going to be talking about. So the first thing I want to just talk a little bit about what is operative vaginal delivery and when do we use it. I want to go over the temporal and regional trends of the use of these deliveries in Canada, and then talk about trauma rates in a particular kind of operative vaginal delivery called mid-pelvic operative vaginal delivery, which I will describe in a few moments. We're going to look at trends in maternal trauma and neonatal trauma. We're going to talk about an important relationship between episiotomies and operative vaginal deliveries. And then I'm going to talk to you about some very recently published work looking at maternal and neonatal trauma with operative vaginal delivery in the country, across the country, using a regionalization framework. And we'll close by thinking about what these trauma rates in Canada, how we measure up to other countries, looking at some international comparisons of trauma with these deliveries or among these deliveries. And we'll talk about some of these quality of life impairing long-term consequences that are associated with these traumas. And finally, what should we do next? What are the next steps? So first, I just wanted to talk about when do we use operative vaginal delivery? So this schematic is just showing us that once a laboring individual is fully dilated and she's in the pushing stage or the second stage of labor. So during the stage, if there's a complication that halts the progression of an unassisted vaginal birth, so a spontaneous vaginal birth. So this is, for example, when there's an arrest in the fetus's descent in the birth canal, or when there's a need to expedite delivery, when there's an imminent risk to the fetus, for example. So in scenarios like this, there are two options that remain when that spontaneous or unassisted vaginal delivery option is no longer available. So these two options with respect to mode of delivery are first operative vaginal delivery. So these are deliveries that involve the use of instruments, so obstetric forceps or vacuum or a combination of those instruments to extract the fetus vaginally. And the second option, of course, is the surgical alternative, and that's cesarean delivery. And it's important to note that if option one, or if forceps or vacuum extraction fail, so if an attempt at an operative vaginal delivery is unsuccessful, then option two ensues and you have a cesarean delivery. So the reason why operative vaginal delivery kind of showed up on my radar was in 2014, this consensus statement was put forth by the American College of Obstetricians and Gynecologists and the Society for Maternal and Fetal Medicine. And they proposed in this document a number of strategies to reduce the primary cesarean delivery rate, one of which was a recommendation to increase the use of operative vaginal delivery. So they wrote, OVD in the second stage of labor should be considered a safe, acceptable alternative to cesarean delivery. And this recommendation seems entirely reasonable because over the last few decades, as we see here in Canada, illustrated in this figure, as well as in a number of other industrialized settings, as cesarean deliveries have increased, we've also seen these concurrent declines in operative vaginal deliveries. So it makes sense to assume that increasing operative vaginal deliveries would have this potential to prevent and reduce our cesarean delivery rate. It's important to note that as these operative vaginal deliveries have declined in frequency in Canada, the training opportunities in these deliveries has also declined. So this is a table just showing the results of two surveys of the 16 Canadian residency programs. The first row is showing two surveys in 86 and 91, in which they showed that the obstetric residents having exposure to forceps, the range, so the number of forceps deliveries that were performed or assisted by these residents was between 50 and 80. And a subsequent survey more recently in 2017 found that this number was between 1 and 12. I also just want to say that there are some operative vaginal deliveries that are more appropriate alternatives to cesarean delivery than others based on different factors. And one of these key factors is a measure called pelvic station. And this measures the descent of the fetus in the birth canal by identifying the point of the fetal skull in relation to the maternal pelvis, and specifically the ischial spines as shown in this diagram. So if this measure is 0, or above, then operative vaginal delivery is contraindicated. It can't happen and only a cesarean delivery can be performed. If the if the fetal head is between 0 and +2, we term this mid-pelvic station. If it's +2 and below, this is low pelvic station. And if the fetal head has descended enough to have reached the pelvic floor and is on the perineum, this is outlet station. Now, this is important because not only are the rates of safety different with respect to trauma when we compare operative vaginal deliveries at these different pelvic stations, but also the safety of a cesarean delivery at each of these stations is very different. So a cesarean delivery performed when the fetal head is at low or outlet station, so when the fetal head is further down in the birth canal, there's a lot of well-known risks associated with cesarean deliveries because it's very difficult to achieve a cesarean delivery safely when the fetal head is deeply impacted in the birth canal. So when the fetus is at low or outlet pelvic station, then it's intuitive that it would be safer to do an operative vaginal delivery. But it's at mid-pelvic station, so between this 0 and +2 here, where a cesarean delivery would not be as complicated as the head is not deeply impacted in the birth canal, and where an operative vaginal delivery would actually require more skill than it would at low or outlet station. So it seems intuitive that operative vaginal delivery would be a reasonable strategy to curb the rising cesarean delivery rates. But given these shifts in practice that I just alluded to over the last few decades, the question is, can we really consider that they're a safe and acceptable alternative to cesarean delivery in contemporary practice in Canada? So to answer this question, my colleagues and I carried out a number of observational studies in an effort to really understand the profile of operative vaginal delivery use in Canada and the comparative outcomes in operative vaginal delivery and its alternative being second stage cesarean. So the first of these observational studies was this descriptive study that just simply aimed to understand the temporal and regional variations in the use of operative vaginal delivery in Canada, and to do this by pelvic station. And we wanted to do this by pelvic station and get these station-specific rates because it was really important to distinguish, to get that full picture of if there are practice changes in Canada, and if they are, which deliveries are those taking place. So we looked at over 2 million deliveries across Canada, and we obtained data from the discharge abstract database, and we described these trends in operative vaginal delivery by instrument and pelvic station. So in summary, the findings of that work were that we found that operative vaginal delivery use varied widely among the provinces and territories. We found that vacuum was increasingly replacing forceps at outlet and low pelvic stations. And we found that cesarean deliveries were in fact replacing forceps deliveries at that mid-pelvic station. So this inspired us to carry out these 2 studies that compared the perinatal and maternal morbidity and mortality in mid-pelvic operative vaginal deliveries, because this is where the real difference can be made in reducing that cesarean delivery rate. If we were able to increase mid-pelvic forceps or vacuum delivery, we would probably be able to reduce those cesarean delivery rates. So we decided to look at these comparisons, and we did this in these 2 studies that differed. They differed by data source, one being pan-Canadian hospitalization data, and the other being from a provincial perinatal data registry with some more granularity in the clinical data included. They also used 2 different methodologic approaches. So one used a multivariable logistic regression model, and the other used a multinomial propensity score analysis. And the primary outcomes of these studies were severe perinatal and maternal morbidity. And as much as I would love to go into these findings, they're really beyond the scope of this presentation. But the secondary outcomes in each of these projects are relevant, as they were composite maternal and composite neonatal trauma, what we're talking about today. And I did want to take a moment to review how we've been defining these primary outcomes. So here, these are the subtypes of maternal trauma that we included in our maternal trauma composite outcome. And this is an outcome that we've used in all the studies that I will be talking about today. So in this composite, we included obstetric anal sphincter injury, which is defined as 3rd or 4th degree perineal lacerations, cervical or high vaginal laceration, pelvic hematoma, obstetric injury to the pelvic organs, joints, or ligaments, injury to the bladder or urethra, or other pelvic trauma. And this is an indicator that the Canadian Institutes of Health Research use in their safety indicators as well, defined in the same way. Now, when we looked at neonatal trauma, was also a composite outcome, which included intracranial hemorrhage and laceration, skull fracture, severe injury to the central nervous system and peripheral nervous system, fracture of the long bones, and injury to the liver or spleen. So it's important to note these don't include minor injuries. These are all have the potential to have long-term permanent damage. So we're not looking at minor lacerations. These are all severe traumas. I wanted to take a second to talk about some of the validity of the perinatal information in the data sources that we used. So validation studies on this information in the discharge abstract databases coded with ICD-10 codes has found that most maternal obstetric and neonatal indicators showed a high degree of accuracy. So this table here is showing some key results. In particular, severe perineal lacerations had a very high sensitivity and specificity rate. We see rates of sensitivity of 97.1, 94.7, and 34th degree, respectively, and specificity rates of 99.9 in both. The accuracy of neonatal morbidity diagnoses are also high. Also, additionally, in 2015 and 2016, a reabstraction study carried out in hospitals across Canada showed very high agreement for obstetric trauma. Specifically, we can see here rates of agreement of 97%. And finally, as I mentioned, obstetric trauma is one of CIHI's national health system safety indicators. And as such, it's scrutinized routinely for data quality. And if there are suspect findings, they're communicated back to the submitting facility. So it's looked at constantly and carefully. So back to the results of those two studies. So now what we did in these two analyses is we stratified the cohorts by indication for operative delivery into those that were indicated for operative delivery due to dystocia, so an arrest in that descent, or for fetal distress, so if there was risk to the fetus, because we knew that these were different scenarios. And this was our first real discovery of these very high rates of trauma among these deliveries. So in the first study using these hospitalization records across Canada, we found, so this is a table showing that among mid-pelvic forceps, vacuum, and sequential deliveries, maternal trauma rates of 22.9, 15.4, and 22.2%. And these rates of neonatal trauma, which are now per 1,000 live births, and right now I should mention we're talking about in women who are indicated, or excuse me, individuals indicated for operative vaginal delivery due to dystocia. The neonatal trauma rates were 7, 7, and 14 per 1,000 in these three groups. When we looked at these same rates in individuals indicated for OVD due to fetal distress, the rates of maternal trauma were similar, 22.8, 15.6, and 22.9, and the neonatal trauma rates were higher at 12, 10, and 25 per 1,000. And when we looked at the subtypes of maternal trauma that composed these high rates of trauma, we found that approximately 90% were obstetric anal sphincter injuries. So this is the same table in the same group of individuals in these two different tables. But right now we're showing that among these trauma rates, that 18.7%, for example, of this 22.9% rate was due to obstetric anal sphincter injury. So we can see that in all of these groups and in both indications that it's really these OAZs that are driving these high maternal trauma rates. Now this figure is illustrating the rate of obstetric anal sphincter injury and of these 95% confidence intervals by indication and instrument in the second study. So this is using the provincial data set. And we can see that there's the three instruments listed in the x-axis and the dystocia indicated group in maroon, fetal distress in mustard or orange or yellow on my screen at least. And really there are two take-home messages that this figure should give us. The first is that the rate of obstetric anal sphincter injury was high across the board with rates of 8.5% to 23%. And the second is to really digest that the fact is that in Canada, the average woman who's having a trial of mid-pelvic forceps has a 20% or greater chance of having an obstetric anal sphincter injury. But remember, those outcomes were among individuals with mid-pelvic operative vaginal delivery. And remember, I mentioned that it's those operative vaginal deliveries that require the most skill. So surely when we included in our analysis outlet and low operative vaginal deliveries, surely the rates would be much lower. And this is what we wanted to see in this analysis that included over 60,000 deliveries across Canada, again, stratified by indication into dyssocia and fetal distress groups, using hospitalization data from the DAD. And what we did in this analysis was see if we could find a significant modification in that relationship between operative vaginal delivery and trauma by pelvic station. So, what we would expect to see was that there'd be kind of a dose response dependent on pelvic station, with the lowest rates being in the outlet group and the highest rates in the mid-pelvic group. So what we found was that with respect to neonatal trauma, we did find modification by pelvic station in vacuum deliveries, but not forceps. And then in maternal trauma, we found modification by pelvic station in individuals with dystocia, but not fetal distress. But again, by far the most compelling result of this analysis was just the crude rates of obstetric anal sphincter injury. So we can see here in this table that these rates are separated by indication, they're separated by instrument, and each of these bars are representing the rates of obstetric anal sphincter injury by pelvic station. And I'll bring your attention to the far left bar, which is the rate of obstetric anal sphincter injury among outlet operative vaginal deliveries, outlet forceps deliveries in individuals with dystocia, having a rate of 18%. And when we look at that same bar in that fetal distress cohort, we see that that rate is closer to 25%. Now, this is that same figure, but here I'm showing these rates of OAZ in these same groups of women, but these black and white bars, or full and open bars, are showing with and without episiotomy. The solid bars are episiotomy, the open bars are no episiotomy. And what's important to note here is that women who had a forceps delivery with an episiotomy had a significantly lower rate of OAZ compared to those who didn't. And that was not evident with vacuum delivery. And I should mention here that we didn't have information on type of episiotomy, whether it was median or medial lateral, but we know from some more detailed provincial databases that there's a very small proportion of these would be median episiotomies. So what do we know? We know that operative vaginal delivery is strongly associated with increases in maternal and neonatal trauma, and we know that rates of trauma are high, irrespective of pelvic station. What don't we know? Well, what are the temporal trends of these injuries in Canada? What do they look like? Are they increasing? Are they decreasing? Are they stable? And can we estimate population level relationships between the rate of operative vaginal delivery and the rate of maternal and neonatal trauma? So what this question is really getting after is, if we do what that recommendation says and we increase our rates of operative vaginal delivery, what is that going to look like with respect to rates of maternal and neonatal trauma on a population level? So these are the questions we sought to answer in this analysis, where we looked at trends in these traumas and how they're associated with operative vaginal delivery rates on a population level. So to do this, we looked at over 1.9 million births between 04 and 14 using discharge abstract database again. We stratified in this analysis by parity and previous cesarean delivery into three groups of women: nulliparous women without a previous cesarean delivery, and women with a previous cesarean delivery. And our primary outcomes in this work were maternal and neonatal trauma. Now we're looking straight on at these traumas. By this point, we knew that this is where we really needed to focus. And in this work, we looked at these temporal trends in maternal and neonatal trauma, and we used ecological random intercept Poisson regression to measure that association between the absolute increases in operative vaginal delivery rates and the relative effect on rates of maternal and neonatal trauma. And of course, we adjusted for a number of factors listed here. So this graph is showing us the rate of maternal trauma between 2004 and 2014 among nulliparous women alone. And what we saw was that the overall rate increased from 6.6 to 7.2, which is a significant increase, but maybe not all that dramatic. But then when we stratified by mode of delivery, we see that among operative vaginal deliveries, this increase in maternal trauma rate was much more pronounced. So we see that increase was from 16.6 to 19.4 among operative vaginal deliveries. And then when we further stratified by instrument, we showed that while maternal trauma increased in all these instruments, forceps, vacuum, and the sequential application of both, the greatest increase occurred among forceps deliveries. So we can see this increase from 19.4 to 26.5%. And with respect to neonatal trauma, so we can see in panel A here, this is the overall rates of severe birth trauma over the study period, and it didn't change appreciably over the study period. This is again restricted to the nulliparous group. But in panel B, we see that again, when we look specifically at operative vaginal deliveries, there's a significant increase from 4.5 to 6.8. In panel C, we see that the most pronounced increase was among vacuum deliveries and sequential deliveries. So keep that in mind. And the results of that ecological Poisson regression I told you about showed us that there was this positive association between operative vaginal delivery rates and maternal trauma. So for example, we see here let's look at the row for forceps deliveries. We see an adjusted rate ratio of 1.09. And what this tells us is that a 1% increase in the rate of forceps delivery is associated with a 9% relative increase in maternal trauma with forceps deliveries. And this is among nulliparous women alone. And what this translates to is 1,061 excess cases of maternal trauma per year among nulliparous women, given a 1% increase in that forceps delivery rate. And that equivalent rate in nulliparous women with forceps was 708 excess cases. So to summarize those findings, we did see those increases in maternal trauma among operative vaginal delivery that occurred as the operative vaginal delivery rate declined by 11%. So what does this suggest? It suggests that the safety of operative vaginal delivery is declining, and we see that this is especially the case with forceps. Now, is this due to a decline in expertise? Are we becoming less proficient in selecting candidates for these deliveries? Or maybe are we reserving these deliveries for the most severe cases? These are questions that remain unanswered, given the information we had in this study. But what we did find, and what we can say, was that we saw these 6 to 11% increases in maternal trauma, given those 1% increases in operative vaginal delivery, dependent on what instrument is used. So I mentioned a whole bunch of unanswered questions, and one of the ones that we really wanted to see was we wanted to investigate some of those potential reasons for why we were seeing those increases in maternal trauma rates. And given what I showed you earlier with respect to the rates of OAZ in women with and without an episiotomy, and also what's been shown in many other previous studies to be as being a really important modifiable risk factor, we really wanted to take a close look at episiotomy use across Canada, especially its use with operative vaginal delivery. And we wanted to look at whether there was any association between episiotomy and these injuries in operative vaginal delivery specifically. And I'll mention again that this included both midline and mediolateral episiotomies, but we know that mediolateral episiotomies represent more than 95% of these cases in the country. So to look at these associations, we looked at 2.5 million deliveries between 2004 and 2018 in Canada, excluding Quebec, using our national hospitalization data. And we contrasted deliveries with and without episiotomy among different modes of vaginal delivery. So we looked at spontaneous vaginal delivery, so those that did not include assistance with instruments, and then those that did. Again, we stratified our analysis by parity and previous cesarean delivery. And here our primary outcome was simply obstetric anal sphincter injury. We looked at the temporal trends in the use of episiotomy in these different modes of delivery. And then we used log binomial regression to measure that association between episiotomy and obstetric anal sphincter injury in these different groups of women, and adjusted for a number of factors listed here. Our findings on the temporal trends in nulliparous women are shown in this figure. So we see that the rate of episiotomy declined from 2004 to 2017 in spontaneous vaginal deliveries. And that's the yellow line at the bottom, as we would expect. But we also saw these declines in episiotomy in forceps and vacuum delivery, which are entirely surprising as there's no evidence that this should be occurring. Now, these figures are showing the adjusted rate ratio for obstetric anal sphincter injury in deliveries with episiotomy versus without. And they're plotted in these 4 panels, showing these estimates in panel A, spontaneous vaginal delivery, B, forceps delivery, C, vacuum delivery, and D, the sequential use of both. And the horizontal line in each of these panels represents the null value. So values above indicate higher rates of OAZ with episiotomy. Those below indicate lower rates or a protective effect of episiotomy with respect to this obstetric anal sphincter injury. So we found what was to be expected among spontaneous vaginal deliveries, that episiotomy was not protective against obstetric anal sphincter injury, and in fact was associated with higher rates of these injuries, which has been, this reproduces evidence that has been shown in several randomized trials that have been done over the last few decades. However, look at panel B. Among forceps deliveries, we saw episiotomy was associated with lower rates of OAZ in nulliparous women and those with a vaginal birth after cesarean, but positively associated with obstetric anal sphincter injury in parous individuals without a previous cesarean delivery. Oops, sorry. Now, when we look at when we look at these estimates among vacuum delivery, we see again this protective effect among nulliparous women, no effect in women with a vaginal birth after cesarean, and an increased rate of obstetric anal sphincter injury with parous women with no previous cesarean delivery. And the sequential instrument effects were very similar to those with forceps, just with wider confidence intervals due to a lower rate of frequency of events. So what are the findings in this analysis? We saw these significant declines in the use of episiotomy among vaginal deliveries, particularly among these operative vaginal deliveries. Now, among spontaneous vaginal deliveries, we saw what we expected, that episiotomy was associated with higher rates of obstetric anal sphincter injury. But among operative vaginal deliveries, we saw that these associations were not straightforward and varied by parity, obstetric history, and instrument, where, for example, in nulliparous women, we saw up to 47% decreases in the rates of these injuries with forceps deliveries with an episiotomy, and up to 20% decreases with vacuum. So let's summarize the findings of all these different observational studies I've just talked about. First, okay, we know operative vaginal delivery is a strong risk factor for maternal and neonatal trauma. 2, rates of maternal trauma and neonatal trauma are high in operative vaginal deliveries, irrespective of pelvic station. We know that operative vaginal delivery rates are declining, especially with forceps, that rates of maternal and neonatal trauma are increasing, especially with forceps. We know as that operative vaginal delivery rates increase, that we can expect trauma rates to increase. And we know that rates of episiotomy with operative vaginal delivery are decreasing. Lastly, we know that episiotomy is associated with lower rates of these severe injuries in women in vaginally nulliparous, so vaginally nulliparous individuals, so women who have not had a previous vaginal delivery. But this was not true in individuals who had a spontaneous vaginal delivery or individuals who did have a previous vaginal delivery. Important distinction. So we return to this question: should OVD be considered a safe, acceptable alternative to cesarean delivery? Well, we can talk about that, but what we can say is that encouraging OVD as an alternative to cesarean delivery without either increasing skills in our performance or our selection of candidates for these deliveries may lead to increases in maternal trauma and in neonatal trauma in Canada. So when the new iteration of the OVD guidelines were published in June of 2019, we expected that these high rates of trauma that we had been publishing about over and over would be highlighted. Instead, on the subject of obstetric anal sphincter injury, the guideline reads, it's generally accepted that OAZ rates are higher with assisted vaginal birth than with spontaneous vaginal birth and are higher with forceps than with vacuum delivery. A recent review suggests an OAZ incidence of between 4 and 6.6% of all vaginal births, including those by operative vaginal delivery. Further, it's asserted that overall, in carefully selected circumstances, both vacuum and forceps are associated with relatively low rates of serious morbidity and mortality in both mother and baby. And lastly, on the topic of episiotomy, we find the recommendation that restrictive use of mediolateral episiotomy is supported in assisted vaginal birth. Now we'll return to that, but I want to shift gears and talk about the fact that around the same period, a CIHR grant facilitated the formation of this excellent team of researchers, over 70 researchers, clinicians, perinatal program managers, all with the shared objective to improve perinatal healthcare regionalization in Canada. And what really the overarching goal of this team was, it was to evaluate, or is, there's still very active, is to evaluate the effectiveness and the safety of perinatal care regionalization in Canada. And to do this by really assessing or comparing the functioning of hospitals under the existing perinatal regionalization framework that exists in the provinces and territories of Canada. So this has been achieved by this group thus far by the publication of 3 different reports that address the safety and frequency of deliveries based on mode of delivery. So these reports exist for women with, individuals with attempted forceps and attempted vacuum delivery, individuals with primary cesarean delivery, and individuals with deliveries to individuals that have a previous cesarean delivery. So the outcomes that were compared in each of these reports are listed below the group. And in each of these reports, the rates of these outcomes were quantified by province and territory, by tier of obstetric service, and by hospital. So of course, I was supremely interested in the first analysis evaluating the safety of operative vaginal delivery using this regionalization framework. So that report and that analysis was what resulted in the most recent study that was published earlier this month, characterizing maternal and neonatal trauma following operative vaginal delivery in Canada under this regionalization framework. So this recent study used 1.3 million deliveries across Canada between 2013 and 2019 that were accessed from the Discharge Abstract database again. And what we did in this analysis was contrast rates of trauma with attempted operative vaginal delivery by province and territory, by tier of obstetric service, and by annual hospital delivery volume. And our primary outcomes were maternal and neonatal trauma. For these analyses, we used 3 different approaches. First, we used a log binomial regression model to assess the relationship of these rates and different modes of delivery. So we compared vacuum versus forceps, adjusted for a number of factors. We then used mixed effects logistic regression to estimate adjusted and stabilized rates of trauma. So these were adjusted analyses of trauma rates across the country against the national average using this adjusted and stabilized model. And lastly, we used ecological Poisson regression to quantify that association between volume of operative vaginal delivery at the hospital level and rates of trauma to really answer the question, if you perform a certain number of forceps deliveries per year, are you achieving a level of proficiency that would translate into lower rates of trauma? So these analyses, we included a 1.3 million I mentioned, and this was singleton deliveries at term. The second blue box from the left shows that 11.3 of these deliveries were attempted operative vaginal deliveries. And this 11.3 was composed of 2.9% attempted forceps deliveries and 8.4% attempted vacuum deliveries. I did want to take a moment to review the primary outcomes. So the maternal trauma outcome is exactly the same as we mentioned earlier. The neonatal trauma outcome was the same, but also included neonatal seizures and neonatal death. So this table here is showing us the results of it's listing the frequency of this composite maternal trauma outcome among the attempted forceps and vacuum delivery groups overall. And what we see here is that maternal trauma was common, following forceps deliveries. Excuse me, just taking some water. And they occurred in 1/4 of these deliveries. So we see this with this 25.3% rate of maternal trauma with forceps. With vacuum, maternal trauma was less frequent than with forceps, but still high at 13.2%. And again, we saw that OAZ was the most common trauma subtype with both forceps and vacuum, with rates of 21.5 and 11.7% respectively. Now this is a similar table, but now we're showing the frequency of the composite neonatal trauma outcome. And keep in mind that these rates are expressed per 1,000 live births. We see that the neonatal trauma rate was 9.6 per 1,000 live births in both instruments. And we found that brachial plexus injury and seizures were the most common subtypes. Now we'll take a look at the rates of maternal and neonatal trauma with operative vaginal delivery stratified by province and territory. So here we see the variation in maternal trauma by province and territory, with attempted forceps in the blue bars and attempted vacuum in the orange bars. And on the far right, we see the overall rates in Canada that I mentioned earlier, 25.3 with forceps, 13.2 with vacuum. And what we found was that rates of trauma following forceps deliveries were significantly higher in Alberta, Saskatchewan, Manitoba, Nova Scotia, and PEI than when compared with the rest of Canada. Rates of trauma following, this is maternal trauma, rates of maternal trauma following attempted vacuum delivery were significantly higher in Saskatchewan, Manitoba, and Nova Scotia compared with the rest of Canada. And I should mention that here CT represents a combined territories group. This is a similar figure showing the variation in neonatal trauma by province and territory. Again, on the far right, we see those national rates of 9.6 per 1,000 with both instruments. No province or territory had a rate of neonatal trauma that was higher than the rest of Canada with forceps, but with vacuum, there were significantly higher rates in Alberta and PEI. Next, we looked at variation in trauma with operative vaginal delivery by tier of obstetric service. So tier of obstetric service is basically measures the level of obstetric care in Canadian hospitals, and it's designated by tier, which ranges from 0 to 3 or 4, depending on the province's system. And it reflects the availability of increasing complexity of care. So you would expect that in higher tier of service hospitals, you would have a higher complexity of care provision. So here we see hospitals, I should mention that hospitals in tier 0 and 1 were excluded because operative vaginal deliveries in those institutions are rare or unsupported. And so this figure here is showing an example of maternal trauma rates by tier of obstetric service in Alberta. So the first thing to note is that the rate of maternal trauma was significantly higher with forceps than with vacuum, which isn't surprising. But what's important and I think unexpected is that the rates of maternal trauma were similar across levels of care. Drilling down to the hospital level. So our last analysis was carried out because we wanted to see if there was a relationship between the volume of operative vaginal deliveries performed in a hospital and the rate of trauma with operative vaginal delivery in that hospital. And so for this analysis, we related the annual volume of forceps or vacuum delivery in a hospital with the rate of trauma with that instrument in that hospital. And of course, adjusting for a number of covariates. They're listed at the bottom of the slide. So the spline on the left is showing the adjusted rate of maternal trauma among forceps deliveries decreased as hospital forceps use increased up to 30 attempted forceps deliveries per year. And surprisingly, after that, there's no forceps maternal trauma, no forceps volume maternal trauma relationships seen. So, and most hospitals across this range had an average maternal trauma rate of 23 to 25%. And the figure on the right shows that it's similar in vacuum deliveries. So that beyond 200 vacuum deliveries, there was a very constant rate of maternal trauma between 14 and 16%. So the key findings here, the rate of maternal trauma with operative vaginal delivery is high, and especially high in some provinces, tiers, and hospitals. We saw hospitals in the highest tier of service also have extremely high rates of trauma, even after adjustment for a number of factors. We also found that whether a hospital performed 30 or 450 forceps deliveries per year, the rate of maternal trauma was between 23 and 25%. And similarly, those that performed 200 or 1,000 vacuum deliveries per year, the rate of maternal trauma was still constant, between 14 and 16%. So how does Canada compare to other countries with respect to trauma associated with operative vaginal deliveries? Are these rates, high rates, being seen everywhere? So comparative statistics are routinely published by the OECD, and they have regularly characterized Canadian rates of maternal trauma as being the highest among member countries. So we see here that the average rate of obstetric anal sphincter injury among these 24 OECD countries was 5.3 in this orangey bar. And Canada stands out with the highest rate of 16.3%. Now, this is lower than our 20, it's between our rates of forceps and vacuum because it's an aggregated rate of trauma in both forceps and vacuum combined. But I need to mention that this unfavorable position of having the highest rates in these comparisons was true, not just in 2019 when these data were published, but also in 2015 and 2017. So this is a consistent finding. Now, some of these differences between countries can be, it's likely due to measurement and reporting differences, type of instrument use. We know some of these countries have abandoned the use of forceps, for example, but it's very clear that there's something beyond those measurements, those reporting issues going on, especially when you consider we're being compared against countries like Sweden and the United Kingdom, where we know that their reporting systems have highly valid indicators. Now, the logic might be that our countries may have lower rates of maternal trauma, that other countries may have lower rates of maternal trauma, but that must be a function of higher cesarean delivery rates. Now, this figure is really busy, and I apologize for that, but pay attention to the orange portion of the bars at the bottom of each bar, which represents the cesarean delivery rate in each country and is measured against that primary y-axis on the left. And then the black diamond markers, which show the rate of maternal trauma with operative vaginal delivery, and those rates are measured on the secondary y-axis on the right. Okay, so what this shows us is that there's several countries like Finland, Norway, and Sweden, and the Netherlands with cesarean delivery rates far lower than ours, and maternal trauma rates also substantially lower. So these high rates have been reported from other groups as well. Just notice here, Canada's in the blue line, and compared to Norway, Sweden, and Austria, we're having higher and increasing rates of obstetric anal sphincter injury with forceps deliveries. The same is true with vacuum deliveries with these increasing rates. But this is a good moment to address the question, what does it mean clinically for an individual to even have this injury? Are there any long-term consequences? Should we even be concerned? So OASI accounted for, so let's just say that we know that there are several long-term consequences of obstetric anal sphincter injury, like urinary incontinence, dyspareunia, pelvic floor disorders, but probably the most distressing of all is anal incontinence. So rates following the primary repair of OASI have been estimated to be between 15 and 61%, with a mean of 39%. And these rates increase with time up to 54% at 3 to 8 years following a delivery. Now, there are several studies that have characterized these associations, but I wanted to highlight this one mainly due to its long follow-up of 20 years. And what this group did was looked at fecal incontinence in individuals with no 1 or 2 OASIs in a cohort of Swedish women. And what they found was fecal incontinence rates of 11.7, 23.7, and 36.1 in women with no 1 and 2 obstetric anal sphincter injuries. Now, I should mention fecal incontinence is the involuntary loss of liquid or solid stool. Okay, so this graph, which really hits me hard because it shows the difference in fecal incontinence in individuals by age group, shows that 26.3% of individuals who had an OASI had fecal incontinence by the time they were 44 years old. And I have to agree with the authors of the study when they describe the clinical implications of their work in this way. They say the long-term consequences of one OAZ, and more so after two, are appallingly bleak. And the risk of repeat OAZ is distressingly high in women with OAZ at first birth. This information must be communicated to women as part of the antenatal consultation. Avoiding sphincter injuries would most probably significantly reduce the severity, postpone the onset, and even prevent the occurrence of fecal incontinence. So I just wanted to say in the end, what can we do about it? So again, earlier this month, this team for improvement of perinatal care, Regionalization, published a related report on the safety of operative vaginal delivery in the 386 hospitals included in the overall team study. And each hospital in the country, excluding those in the province of Quebec, that have had a delivery between 2013 and 2019 are included in this report. And this is an excellent resource that can be used by anyone to see the rates of trauma occurring in your institutions. They're compared between provinces and territories and tiers of obstetric service. And we can see high rates compared with, you can see like the high rates compared with other groups that have comparable factors. What we need to do about this, in my opinion, is urgent. We need to be transparent about these rates of trauma with pregnant individuals. As you saw in the guidelines, this is hardly the case. Ideally, we would be able to talk about this antenatally. We have to be clear that operative vaginal deliveries are invasive procedures with substantial risks that need to be disclosed. The failure to do so compromises individuals' autonomy in making these evidence-informed decisions regarding childbirth interventions, like evaluating short and long-term risks of operative vaginal delivery. And this also highlights the need for routine surveillance of perinatal indicators. Just the frequency of OAZ that we found in our study compared to those reported in current guidelines highlights the importance of reporting empirically derived and timely measures of risk that reflect those that pregnant individuals would encounter in typical obstetric practice and not in ideal scenarios that happened historically. So a moment to acknowledge my incredible co-authors. There are far too many to include. The whole list of team members of the CIHR team for improving perinatal care is available at this website, as are the 3 reports I mentioned earlier. And I'd like to acknowledge my funder, CIHR. I've included my email and the URL for that team. I'm happy to share my slides with anyone who's interested, and I look forward to talking with you about what you think about all this work.
Thank you so much, Julia. I'll jump right into the Q&A because we only have we have 5 minutes till we have to be gone from this shared platform. There was an early question, so I'll maybe let you go back to your early slides. There was a graph at the beginning around slide 5 or 6-ish. Someone was asking if it includes persons who have had C-sections previously. So maybe if you want to circle back to that,
Let's check here.
I don't know if it was answered subsequently. And I will just state again for everyone who has typed a question in, if we don't get to your question before we wrap up here, Dr. Maraca will be able to respond to you personally via email to address those questions afterward.
So if it corresponds to slide 6, which is showing the overall mode of delivery trends, yes, it does include women. It includes all women with that had a cesarean delivery between the years of 2002 and 2020. So
okay, including those, yeah, perfect.
If we're
next question is, do we have the stats for rates of neonatal trauma for 2nd stage cesarean section?
Yes, so we do. Those are in those 2 papers that I cited. So I can send you the link. There were also comparable rates of severe neonatal morbidity and mortality associated with 2nd stage cesarean delivery, particularly in that fetal distress group. And so we did see that there were, wonder if I have these results that I can share with you. It's complicated because there were the different stratified groups based on indication, and then again different groups based on parity and instrument used. So the answer is yes, there was comparable rates of severe neonatal morbidity and mortality. So this I'll leave it at that, and perhaps I can have a longer conversation with people who are interested in that question in a different forum. But I just want to use this as an opportunity to say I'm not recommending that we use cesarean delivery over operative vaginal delivery. Really, just the fact that we need to acknowledge that there are significant risks with both, and to make sure that women can or individuals can decide for themselves which risks are applied to their own kind of personal values and framework when they decide on the course of their delivery experience if they encounter these scenarios.
Great, thank you. Okay, so I think we have time for one more. We're at 3 minutes. Did you have rates for trauma for forceps and vacuum in the 1980 to 1990 period? I wonder whether there's been an increase in these rates recently because of poor or inadequate training provided by the universities to future practitioners.
Yeah, I think that range of forceps deliveries that residents have been exposed to being so much less in 2017 than in the late 80s, early 90s that I mentioned would agree with that suggestion. And that's definitely where, I've been involved in a lot of focused discussions about how to improve the quality or whether we should just stop doing forceps deliveries in some centers because of these high rates. And most of these discussions center around the fact that we're probably not training. Recent graduates of obstetric fellowship program, like they're so used to cesarean delivery that there's a lot more comfort using cesarean delivery, and there's a lot more litigation associated with botched operative vaginal delivery. So it does make sense that we're just doing them less and not getting enough training to be able to do them well. And if you look at rates of obstetric trauma in the 90s and even earlier, you do see that there are lower rates, but the definitions are very different, and it's hard to say. It's really hard to compare compared to these rates in what we're seeing nowadays, because often you don't report disaggregated rates by instrument. So I agree with you. I think that is a line of inquiry that I think if we look further down, we're probably going to see it being one of the reasons that we're finding these high rates.
Perfect. Well, that concludes our time on this platform. We do have to move along because it's a shared platform, but as I mentioned, Dr. Maraca, you'll receive the outstanding questions from the Q&A, and you're welcome to follow up directly with the people who asked them from there. Thank you everyone for attending, and thank you, Julia, so much for presenting today. It was fantastic.
Thanks everyone for participating.